It's 2:03, so let's go ahead and get started because we have a full agenda today. I'm going to turn it over now to Jonathan Webb.
Sorry, I started talking without unmuting myself. Thank you so much, Amy, and thank you all as usual for your time this afternoon or this morning, depending on where you're dialing in from, and for your attention to this issue and what's going on around us. We really appreciate all of your hard work and sacrifice with respect to COVID. As I shared on the last call, I consider myself to be really privileged to work with all of you, knowing how much you're doing, how much you're sacrificing, and how you're truly supporting and advancing the health of the communities that you serve. Really, thank you for your leadership. I also, on a personal note, wanted to say thank you for your grace and space to be a bit vulnerable last week in my comments to the membership. There's a lot of there's a lot happening around us, COVID being one of them, obviously, but there's a tipping, what feels like a tipping point in our social dynamic these days with respect to racism and the frustration and angst and anxiety and all of the emotions that are built into that for people of color and for allies in this work. So although I, as a person of color, have been tired, angry, and hopeful, and have experienced a range of emotions, I don't think I've ever been as hopeful and as excited as what I see happening now. The stage seems to really be set for some meaningful change. And this, although we've experienced this as a community in the past, this feels different, and I'm excited to be walking this journey with you. AMCHP is really working to be leaders in this effort, to talk about some of the things that we need to do differently to bring about real change. I've had a number of conversations with leaders on this call in our MCH space who are really interested and excited to be rolling their sleeves up to bring about real change. We're excited to partner with them in that effort. There'll be more to come that we'll be sharing with you. But I'm really excited and proud of the work that we'll be doing together, and honored to have the grace and space among groups like this to be able to be vulnerable. I'm proud of the work that we have done together with respect to racism and structural racism and looking at racism as a public health issue. There are a number of things we've done on the political level. We're starting to have conversations to address that on the individual and personal level. But as I mentioned, there's a lot more work to be done, and it feels, it's always been urgent, but it feels like it's really coming to the forefront of our conversations, and people are rolling up their sleeves to do this work. So thank you in advance for all that you're willing to do and work with us to bring about change in this area. With that, welcome. Welcome again to this call. Welcome to our partners from the CDC, from the Maternal and Child Health Bureau. Thank you for your continued support for this call and for this mission, and for your responsiveness to our members on this call in general, but definitely on this call. I am going to play a smaller role in the conversation today while Amy leads us through our agenda today. I did just want to offer two very quick updates. One, please be on the lookout for the AMCHP path forward with respect to the recent CARES Act telehealth COVID funding. We are working with the MCHB team and with our partners with the APHL, Hands and Voices, NCHAM, the home visiting groups, to really look at ways that we can support the building of the telehealth capacity to respond to COVID in the Title V space, newborn screening space, and in the home visiting arena. So more to come on that. We are working very quickly to conduct a scan, to talk to you, to talk to those programs, to better understand the needs that are out there. All of us have a fairly decent understanding of what may need to happen, but we want to pressure test that against the conversation we're having with you, because we know this is an ever evolving issue and want to make sure we get it right. So please be on the lookout for invitations to have that conversation with us, and for periodic status updates on how to submit applications or submit information on how we can best support you in moving forward with respect to telehealth and COVID. And as I mentioned previously, AMCHP is working on our approach to support the members as you are looking to find a path forward with conversations and direction on how to move this work around structural racism and racism forward to support our programs. So please be on the lookout for that as well. With that, thank you, and I'll turn it over to Amy.
Great, thanks, Jonathan, and happy Thursday, everyone. Just to go over the quick agenda, I'll do a quick legislative update followed by our partner updates from MCHB and CDC. We are also joined today by Dr. Vanessa Jacoby, who's going to talk to us a little bit about the priority study. And then we'll turn it over to Mississippi to do some state sharing. And of course, Q&A are always welcome in the chat box throughout, but we'll have some dedicated time at the end as well. So quick legislative update. The Senate leadership is saying there's not going to be any action on the next relief package until mid-July. As we remember, the House did pass a bill almost a month ago now, so they're waiting for the sort of Senate reply. That means that there's still opportunity to have influence over what's going to be in that bill, but of course, the longer the delay, the further we may see other, budgetary issues that need to be resolved, or other even small technical fixes that need to be resolved by legislation. Just ask everyone to be unmute, please. Thanks. And then I did also want to point out that there are multiple oversight hearings, though, going on in the House and Senate. I just wanted to give you like a little glimpse. On the right side of this slide, you'll see just the ones that are going on today on a variety of different topics. On the left side, those are ones that are specifically in the Senate Health Committee, which has more jurisdiction over health specific, but they include topics like going back to school safely, going back to college safely. There's actually going to be one next week on telehealth, which I think will be really important for us, and in light of the project Jonathan was just talking about, but generally because we know that has been a big issue and concern for reaching MCH populations. So there's a lot going on. Even if there's no specific legislative action, there are other discussions and fact-finding opportunities that Congress is engaged in right now. Another really important update that I wanted to share, I guess not legislative per se, but is important from a federal perspective, is that HHS has announced the enhanced providers for Medicaid and CHIP providers. As you may recall, there was a lot of health provider relief that was included in previous legislation to address COVID-19, but the way that it was first distributed was really relying on Medicare. And as we know, most of the providers who are attending to MCH populations don't have big Medicare patient loads. So we're glad to see that the Medicaid and CHIP provider relief is being released now, and I hope that will help. We know we've been talking about a lot of issues with providers who are having trouble with their own financial situations during this time. And then finally, I wanted to bring your attention to a letter that I mentioned on the last call, but now has been sent up in the House of Representatives, a letter that was led by Representatives Engel, DeGette, Fitzpatrick, and Brooks, bipartisan. It garnered 82 members of Congress, bipartisan again, asking for greater support for Title V in light of COVID response. So we were really happy to see the outcome. And when you get the copy of the slides, which you also would have received in your reminder, but you'll get them again and follow up after this webinar, you can read the full letter and see everyone who signed it. So we were really pleased to see the support for that. And then finally, not to forget the regular business that Congress is still needing to attend to. There's the FY21 appropriations, which interestingly enough, the Senate has said they're going to start markups this month. The House said they're going to have markups in July. And I think it is sort of the duty of the appropriations leadership to always say they're going to get all of the 12 appropriations bills done in time before the fiscal year ends. But I would say the likelihood of a continuing resolution for most, if not all of the appropriations bill is still really high, because even if the House and Senate can get through marking up 12 bills in just a few weeks, they still have to reconcile all of those. And as we've discussed before, with different leadership in the House and the Senate, that becomes a lot harder to do. And I also think they have a lot of extra considerations in terms of the budget caps that had already been put in place previous to the pandemic, occurring, and realizing all of the extra costs that will be associated with addressing that and future needs. But they say their work's going to continue, so we'll keep you posted as that happens. And with that, I will turn it over to Dr. Michael Warren from MCHB.
Thank you, Amy, and good afternoon, everyone. Before I dive into our updates, I want to take a moment. Jonathan, so appreciate your leadership and your outreach to all of us last week, and wanted to let you know that in the Bureau, we continue to have conversations about how we achieve equity. And you all have heard me talk about accelerate upstream together, and I think that message for me resonates more than ever. We have to accelerate our work toward progress in a number of MCH indicators, and part of that involves eliminating disparities, and we do that by thinking upstream, including thinking about social and structural determinants and deliberately thinking about the impact of racism. And so I appreciate AMCHP's leadership in this area. I want you to know the Bureau is committed to achieving health equity across MCH populations. And the together part of that is absolutely true. We can't do this alone. I think so many of us have so much to learn about this journey and ways that we can support populations of color, and ways that we can walk alongside all parts of the MCH population. So thank you for your leadership, AMCHP and Jonathan. Thank you for all that you all are doing in the States. And please let us know what you need from us to support you in this work.
Thank you, Dr. Warren.
So we'll dive into our comments. If we can advance to the next slide, we'll be fairly brief today so that we've got time to continue to hear from you. We can advance. There we go. A couple of things we wanted to talk about specifically. Our colleagues at CDC have raised this issue before and published on this several weeks ago about declines in pediatric immunizations. Certainly that is worrisome to all of us, and we know not only pediatric immunizations, but declines in families going in for a variety of visits, including well child checks. And that is understandable. Families are scared. Families are anxious about potential exposures. Families have got lots of other things to worry about. They're worried about job security. They're worried about financial security more broadly. Maybe safety in their communities. There are lots of things that are going on. And we also know that immunizations and those broader visits in which they occur are so important. And so just wanted to take an opportunity to think about how Title V is so well positioned to make sure that we're getting kids in for immunizations and well child checks. Remember that a third of your block grant has to be spent on primary and preventive care services for kids. So we've long talked about this work in this space. And you've also got a powerful voice as a convener. And so thinking about, are there stakeholders in your state and jurisdiction that you want to engage? How do you serve as a trusted voice for families to get messaging out? How do you work with other public health programs? Maybe they're in your same department, the State Immunization Program, WIC, and others. So wanted to put that call out to encourage you to continue doing that work. I don't want to belabor the time today, but if in the chat box you would comment if there are things that you're doing in your state or jurisdiction to address immunizations or well child checks, we would love to hear about them. The department is very interested in how we continue to advance this work. And so if you'll type in things that you all are doing or approaches you're taking, that would be helpful. Also, if there are particular challenges and places where you need support from us, please let me know. Again, through the chat box or email me. My email and phone is always open to hear from you, and let us know how we can support you in doing this work. Next slide, please. Something else that we have been hearing about for a while relates to our MCH workforce. So we know that throughout the pandemic response, there have been a lot of fluctuations in our workforce. A number of folks have been reassigned, either through the flexibility of the block grant or through some of the Public Health Service Act grants that we fund. And we know that that's a reality and that is happening. We've been very supportive of that. Again, the block gives us a lot of flexibility to reassign folks to work on MCH things, even though it may not have been their primary job. As long as it's MCH related, they can do that. And then there's actually the ability to request temporary reassignment through our Public Health Service Act grants. So we have supported that, continue to support it. We are starting to get some questions from states about returning to, staff returning to their prior roles. And in some cases, we're hearing from states and jurisdictions about concerns that leadership in departments or agencies may not be interested in staff returning back to their prior roles, but rather permanently reassigning them, or even potentially thinking about losing positions. And so we're always trying to understand, is this one state or two states, or is this 20 states? So if that's happening for you, or if that's a concern, if you'll let your project officers know, again, feel free to reach out to me or any of the other bureau leadership, just so we've got some awareness on that. That would be helpful. And with that, I'm going to close. I just want to say thank you again for the tremendous work you're doing. As we think about daunting tasks, like addressing all the things we try to address in MCH, inclusive of health equity, I can't imagine a group of people that is more up for that task than you all are. And so just grateful to be on that journey with you and appreciate your hard work. And AMCHP, thanks for hosting these calls and letting us be a part.
Thank you so much, Dr. Warren. And I see we have some comments coming in the chat. Just a reminder to send it to all panelists and attendees. We'd love to learn more about what you are doing. I'm sure your colleagues from other states would as well. Next, we're going to turn it over to Dr. Kriya Perrine from CDC. Here you can see what her credentials are, both on the emergency response as well as the her normal position. And Kriya, I'll let you take it over.
Great, thank you. Yeah, so CDC as an agency is also not immune from reassigning or temporarily deploying people. So that is typically how we operate a large response like this. So I am currently serving as the deputy for the Community Intervention and At-Risk Task Force, which is where a maternal child health team sits. But in my day job, I lead our maternal infant and toddler nutrition team. So MCH is very near and dear to my heart. And I have heard that this is a great meeting and discussion, and so I'm happy to be here with you today. So what I'm going to do is just give a couple of updates on two topics from CDC. The first related to communication resources and information about face coverings for children, because we've gotten a lot of questions about that, and some resources about contact tracing that were recently released. And Bridget from our policy group in the task force is on, and I believe she's going to be able to pop resources into the chat box as I mention them. So regarding cloth face coverings for children, CDC recommends everyone 2 years and older wear a cloth face covering when they're out in the community. And these should be cloth face coverings that cover both the nose and the mouth. We know that this can be difficult for some children, particularly those with sensory, cognitive, and behavioral issues. And it's not recommended that anyone who has trouble breathing or anyone who is not able to remove the covering themselves without assistance should be wearing cloth face coverings. And then it's always a good idea to remind parents and caregivers that wearing a cloth face covering, say that fast a few times, it is not a replacement for social distancing and hand washing and all of the other preventive measures we take. It's one part of the piece, but it's really from comprehensive measures altogether that we're going to have sort of the best reduction in transmission of this virus. So the other thing I want to mention is the plastic face shields. These have popped up in the news media several times, especially sort of in birth hospitals or with infants. And just to clarify that CDC does not recommend these plastic face shields. There's really no data to support their use as protection against COVID. And it just has the potential to increase risk of suffocation and strangulation. So just the way infants move around, they can get displaced and knocked off, and the straps are sort of a strangulation risk. So even though they have sort of popped up in the news as something that may be beneficial, we do not recommend them. Of course, then the consideration is, how do you protect infants? And so there's other guidance about how to protect infants in the hospital, and especially in the birth hospitalization. We do have a print resource with considerations for cloth face coverings, and a link about sort of how to both take these on and put them on and take them off appropriately. And then on YouTube, CDC has an American Sign Language video about cloth face coverings. And then finally, U.S. Surgeon General Jerome Adams has both a video about how to make your own cloth face covering. And then shifting gears a little bit to contact tracing. So CDC released 3 new tools this past week. The first is a checklist for health departments that are developing plans for case investigations and contact tracing. It's meant to go along with CDC's guidance for health departments on how to develop a case investigation and contact tracing plan. So it's by no means meant to be prescriptive, but it highlights a lot of the areas that states and programs want to be thinking about when they're developing a contact tracing plan. We also developed a daily temperature and symptom log that can be given to close contacts and useful in helping them track symptoms if they have been identified as someone who's been in close contact with a case. And then finally, there's an aid for case investigators and contact tracers to assess the ability of someone to safely isolate or quarantine at home. We know it's not always possible. And so in those cases where it's identified that someone can't safely isolate at home, this tool can help them think through whether they need to try and identify other places for someone to self-isolate. So that covers the updates from CDC. Thank you.
Wonderful. Thank you so much. And all those resources, I hope folks can see some of the links that were placed in the chat, but we will do our best to include those in the follow-up email as well. Now I would like to turn it over to Dr. Jacoby to tell us about the priority registry.
Great. Thank you so much. Hello, everyone, and thank you so much for inviting me to speak to this group. It's a big honor. I'm an OBGYN faculty member at the University of California, San Francisco, and I'm excited to talk to you about our study. The acronym is PRIORITY, which is being run by a multidisciplinary group of researchers from the University of California. Next slide. So we launched the priority study on March 22nd as a nationwide study with a focus to try to address the significant gaps that existed then and actually still exist today about our knowledge of how COVID-19 impacts pregnant people and their newborns. And our focus is try to get answers as quickly as possible while the pandemic is going on to our patients, to providers, to policymakers, to our professional societies about how COVID-19 impacts pregnancy outcomes, birth outcomes, lactation, and newborn health. Next slide. Back one. So health equity is at the center of the priority study. In the first week of May, we launched an official reproductive health equity and birth justice core. And the focus of this core is addressing the disproportionate impact of COVID-19 on Black, Indigenous, and people of color birthing and birthing people across the country. And there are many different activities that this core is working on, including recruitment of BIPOC communities, creating a community advisory council for priority, and then working really closely through community engagement activities with community partners across the country to identify research questions that are most important to highly affected communities that we can address in the priority study, including the effect of racism and other social determinants of health on pregnancy and neonatal outcomes. Next slide. I'm very, very lucky to have this multidisciplinary group of investigators that are leading this health equity and birth justice core, including Monica McLemore from the UCSF School of Nursing, who's leading this core activities. Next slide. So just briefly about the mechanics of the study. So participants can enroll in the priority study if they are at least 13 years old. They have to be currently pregnant or have completed pregnancy in the last 6 weeks. And we're enrolling people who are either under investigation or suspected of having COVID-19 or who have a confirmed diagnosis. We can enroll people from anywhere across the country who speak any language. So to date, we've had about 250 people referred who speak 17 different languages, and we're able to enroll people in the language that they prefer through medical interpreter use. We also can enroll people who are very ill in the hospital, including in the ICU. Even if they're on a ventilator, we enroll them through proxy consent of their medical decision maker to be sure that we understand the deep impact of COVID-19 on very ill people. Next slide. So who's enrolled in our study so far? Well, I'm happy to say, excited to share that I think 2 hours ago, this just went live. If you go to our website, you can now click on our priority dashboard. The dashboard shows real-time information about enrolled participants. So I just pulled this morning. We currently have 837 enrolled participants. You can see the COVID status of enrolled participants as well as some of their demographic characteristics. So we've enrolled people from across the country in almost every state. And my apologies to Hawaii. It's actually on the map. You just can't see it on this slide. The average age of the participants is 31 years. The average gestational age is 24 weeks. You can see the race ethnicity distribution of currently enrolled participants, which is about 25% of the participants who self-identify as Hispanic or Latina, about 8% of that identify as Black or African American, about 59% that identify as white. So we know that we have a lot more work to do to enroll particularly Black or African American women who are pregnant or immediately postpartum, because they are have highest number of cases and unfortunately mortality from COVID-19. So our health equity and birth justice core is working on engaging that community in enrollment. Okay, next slide. So how to enroll in priority? There's really 2 ways. The easiest is through our website, but the 2 ways are either pregnant people can refer themselves. So that's what's circled there on the left with 1 click. You can self-refer if you feel that you qualify. If you have a known diagnosis of COVID-19 or suspected of having it, or your healthcare provider can refer you. And so that's the button in the middle of the screen there. As long as the patient gives her permission to release her contact information to the University of California, if she gives permission, then you can refer the patient directly to us, and we will reach out usually within 4 hours to contact the participant by whichever way they prefer: text, email, calling. When you're screened, it asks which way you prefer to be contacted. Next slide. So when people enroll in the priority study, we really ask two primary things. The first is we ask people to complete questionnaires about their health, about their pregnancy, about their newborn care, about lactation for people who that's relevant for. But we ask people to stay in the study throughout the entire pregnancy and then up to 12 months after the pregnancy ends. And we really believe this is a critical duration of follow-up to understand the full impact of COVID-19 on women's health and newborn and children's health. And then when you complete the questionnaires, we try to make this as easy as possible for our participants. They can do it online, we can send text messages, we do it by phone, we can do it on paper, whichever is easiest to engage our participants. And we also ask people to complete a release to get their medical records so that we can get information about hospitalizations. And then on a small subgroup of participants are being invited to provide biospecimen samples like blood, milk, newborn samples to try to understand transmission rates and viral shedding in a subset of the study population. Next slide. Great, and then just to conclude, here's the two analyses that we're working on right now. I hope to be able to share results of this very, very soon with you. But the first two analyses that we're producing are on the course of disease for pregnant people. So most of what we know now in the published literature is about hospitalized pregnant people and what their course looks like. But there's very little, almost no information on outpatient ambulatory pregnant people with COVID-19, and about 90% of our study population is that group, which is the majority of people with COVID-19. So the first analysis is really focused on what does the disease course look like for most pregnant people who get COVID-19 over time? What type of symptoms do they have? How severe are the symptoms? How long do the symptoms last? What's the chance of going to the hospital? And then the second one is we have had, I believe, 250 births so far to people who have a known diagnosis of COVID-19. And so the next analysis, which again, I hope to share information soon on, is about the risk of newborn infection, newborn health, what the hospital course is for newborns born to people who are known to have COVID-19. Okay, next slide. Great, and just to end with funding, we're very grateful for the support that we've received from multiple different foundations, including the CDC Foundation, the Gates Foundation, California Healthcare Foundation. And we're also actively seeking additional resources to support this ongoing work. And again, thank you so much for allowing me to share this. We have a lot more information on the website, and I'm also always happy to speak to people with questions or further engagement as we're actively enrolling, particularly, as I said, in Black, Indigenous, and people of color communities. Thank you. I'll stop there.
Thanks so much. And before we move on to our state sharing, we have a question for you in the chat, asking if the study is also looking at mental health impacts and how maternal depression or anxiety are being impacted.
Yeah, thank you so much for that question. That is being assessed in the study actually in two different ways. We ask people to self-report if they have a diagnosis of depression or anxiety at multiple time points during the study and then up to a year after birth. And then we also have two standardized questionnaires that are scales used to assess depression and anxiety. And we ask people at multiple time points during pregnancy and then after pregnancy. So we agree, we believe mental health is a critical outcome during COVID-19.
Great, thank you so much. And now I'm going to turn it over to Marilyn Johnson from Mississippi. Marilyn, are you on the line? And I just realized.
I'm on the line. Can you hear me?
You are. Yes, we can hear you. Great. All right.
I had to unmute myself. All right. So the MCH experience in adapting to COVID-19 in Mississippi. Like many other states, we've had to adjust to telework for staff because we did not have a telework policy or telecommute policy in place. So that's been an adjustment for us. You have those who love it. You have those who feel like they need to see people in the desk every day to know what they're doing. So, but I think it's going good. A lot of the feedback that we're receiving from it is really, really great. I'm excited about it, of course. So that's been a major adjustment for us as an MCH team here in the state. If we think about the clients we serve, so a lot of us have been deployed. We are all serving in multiple roles. For example, myself, I did work on the call center team where I was taking calls from the community all over the state, COVID-19 related. Also, I am now on the health equity response team, which was formed as a result of some of the data that started to come out about how COVID-19 was affecting. And I'm also doing my other duties as assigned. So a lot of us are in a lot of different areas, wearing a lot of different hats. So that's been an adjustment. So the adolescent health and the family planning staff, both are part of that health equity response team. And we've been charged with distributing community masks and other resources to the underserved populations or underserved communities around the state. In particular, we've done over 100,000 of those, and they go to city government, public schools, community, and faith-based organizations. We had to develop a whole system for that because we didn't have anything in-house to handle that kind of distribution. For early intervention, we have continued to provide our services throughout COVID-19. However, we have run into some issues where we've had to figure out about outpatient screenings and diagnostic evaluations that are not conducted. So we've got to figure out a way to get those caught back up. We've also started to have, well, we're a partnership with the Mississippi Public Health Institute, where we have doula services, and we have invested in virtual delivery with the doula services. That is an innovative approach for us, and they've had to engage physicians and not have physical meetings, and so it's going okay. We've had a few hiccups there, but we're working through those. Sometimes it's just the difference in it being virtual versus the doula being right there with you. So let me see if there are any other highlights. We also have the Mississippi Perinatal Quality Collaborative. We've introduced hosting weekly COVID-19 updates, and these are very, very, very informative because it not only shares perspective from Mississippi, it also shares perspective from other states. I think we've heard from New York, Louisiana, how things are going there, patient numbers, hospital beds, etc. So it's very, very eye-opening. Some of the meetings have covered safe practices in maternal and obstetric hemorrhage, and labor and delivery, post-care, postpartum care, and discussions on high-risk factors surrounding COVID-19 and pregnancy. We did notice, and we still have a concern that there's not enough data collected related to pregnant women and the delivery process in Mississippi, and if they are COVID-19 positive or if they've been exposed. We are looking at opportunities to form a subgroup outside of our response teams that have been deployed for that, because we really see the need to collect that data, because if we don't do it now, we're missing valuable opportunities. And I think that's all I have. I think I only have 5 minutes. I have way more stuff, but I'll just leave it there.
Wonderful. Thank you so much, Marilyn. And I know there's so much we could talk about, but we do want to leave time for asking our questions. So I'll start with a question that I just reposted it so all attendees could see, but it's for you, Marilyn. have you seen more or less turnover staff in Mississippi? And have there been some supports for emotional health that have been put in place or being put in place with Title V and other partners? And the question was from Jerry, and she said they have a helpline called Hope for Healers in North Carolina. Sounds interesting.
So we do, the mayor of Jackson, which is the capital, did introduce a mental health hotline where, you know, anybody from the community, including staff at different agencies, could call in if they needed it. And this is an ongoing thing that the mayor is providing. So that's one initiative. At the health department also, we do have, for MCH, we do have an in-house person which staff can talk to regarding those issues if they see fit. And we also provide some additional services through our HR department. We call it MEA Cares, where there are people there that can talk to staff if they need to. And we've also made it increasingly important that directors, supervisors, and managers are really, really thinking about everything that's going on. It's not just about the impact of COVID-19 right now. There are other things going on in our, you know, in the US, in the country, in the world today that's palpable, and people are having reactions to those. So I've even shared moments with some staff who you know, we've cried together, we've laughed together. So there's a whole lot going on. So we just continue to emphasize, please be open to, you know, staff who may say they can't come today, staff who may emotionally not be available. Just please be open and responsive. So we're continuing to do those efforts.
Great. Thank you so much, Marilyn. So we'll open it up. We have 15 minutes left, and we'd love to devote that time for any questions you may have for any of the panelists who have spoken, or if you'd like to share on response from your state. I'll also say from AMCHP perspective, especially in light of a lot of the work we'll be doing around telehealth, we'd love to hear about any challenges you're facing or any creative solutions that you may have been able to come up with in your state that will potentially be helpful for your colleagues to hear about.
I don't think I answered the turnover question. We have not had nearly as much turnover. So I'm not sure if that's just, you know, people want to maintain their jobs or they're really excited about the telework option. So not nearly as much turnover.
And that actually kind of goes related to one of the questions that Dr. Warren posed about staff reassignment. So again, inviting folks to share about that, or also given some different restrictions and statute between Public Health Service Act and Title V, under which, you know, the block grant, but also MCHB are authorized if you've run up against any challenges with that. And Jess, will you remind me, people can unmute themselves, right, directly? Yes. So those were some of the discussion items. I know a big topic that we saw come up in the past and continues to come are about guidance for returning to school. I will just speak personally as a parent. I mean, it's the topic that we're all discussing all the time, is understanding about if and when and how schools are going to be able to make these decisions to reopen. Even just since our call 2 weeks ago, it'd be great to hear if anybody has more to offer about their participation in their state's efforts around returning to school. Are those happening at the state level? Are they happening on the local level? Do we need to call on folks? Do we have anyone from Arizona? I know this, I've heard it from some folks in Arizona in the past.
Hi, Amy. This is Dawn Bailey from Arizona.
Great. Don, can you tell us a little more about some of the work you guys are doing there?
Yeah, I was actually just typing in the chat, so thank you for highlighting it. So our Department of Education had recently come out with some guidelines for our school districts and charters and private programs to consider. But what's still missing is specific guidelines for our children and youth with special health care needs or our vulnerable, more medically complex population. And I know that some of our School Nurses Association representatives have been reaching out to ask for guidance. My impression is that even from a state level, we're still looking for that guidance from like the CDC to be able to show that these recommendations are coming from the CDC or validated area to be able to help press that message, if that's helpful.
Yes, thank you. Does anybody else have any thoughts or questions about how they're doing that work?
Amy, there's a question in the chat, or comment, and I had a question to back to it, but Kirsten Duckett, her mic is not connected, but says there are state task forces for reopening, including for schools, and there are MCH staff joining many of those, including the school reopening task force. And that's in Ohio. My question to Kirsten, if you can type it in, and to Dawn or others, is as with the collaboration or the task forces that are looking at this, who from those who from the state, from an educational standpoint, are you working with? We've been, as Amy mentioned, been looking at how we can support and share with other states what partnerships they need to build or partnerships they need to be a part of to make sure their voices are at the conversation. So in some states, these relationships may not already be in place. So can you, either in the chat box or folks on the call, provide examples of the types of partnerships you may have in place that are allowing you to be a part of those conversations with education?
So Jonathan, this is Dawn Bailey again. I'll just say that to my knowledge, based on the guidance that came out and the members of the task force, I'm not aware of anyone from our MCH program that was part of the development of it. Not to say that there weren't any conversations, but there were none that I was aware of, and I've not been asked to be a part of that either. So we've just, as the family leader, just encouraging our community to reach out and share their concerns and thoughts on what that may look like from a family perspective, in hopes that that might be included or help push that work along.
Thank you, Dawn. Kirsten's response, our governor and the emergency response has been coordinated task force formation, and they reached out to facilitate the ask for ODH staff to join the task force. Thank you. Are there others that might have relationships or things happening differently in their area? I see Hawaii and New Mexico. In Hawaii, this is a big concern at the state and local level. MCH and Title V school nurses and other personnel are and have been invited at the table to develop and apply guidance. Okay, school nurses, okay. And then Janice from New Mexico, working with early childhood department on guidance for childcare, pre-K and early intervention. The public schools have a task force for reopening older grades, but you've not been asked to be a part of that. Okay, thank you. If there are others with comments around those relationships that you have, or things like those examples of those task forces, it'd be great to get that in the chat box. As I mentioned, some of your colleagues have reached out to us to help to connect the dots and provide some guidance around best practices or what kind of relationships they need to have or should have to make sure they're part of the conversation. So if you have any examples you can put into the chat box or unmute and share, we'd appreciate it. Thank you. I'll turn it back to you, Amy.
Sure. I see that Lynn has shared Utah's guidance. I'm also going to shift topics. Susan Colburn from Alabama shared earlier about how they're using, how they're getting messaging out through the F2F about routine vaccinations and well child visits. Do you have anything to share about that, Susan? And remember to unmute yourself or chat in the chat box. Okay. Well, if not, I'll just reiterate what Susan said earlier in the chat about sharing CDC and AAP guidance through F2F. So that's another important means to make sure that families and parents are hearing from the trusted partners that they have. If we don't have any other questions at this time, oh, Susan said she just could not unmute, but they've shared the resources on all of their social media platforms. Great, thank you. We'll give everyone another minute or two if they have any other questions. In the meantime, I'll put a plug in. We do have another call scheduled for June 25th. That's in 2 weeks from now. We have another comment from Jenny in Hawaii. Part C and EIS guidance on home visitation have been shared with MCHB in Hawaii. Oops. Getting back to the registration. You'll of course receive the follow-up email as soon as the call ends. The recordings are available as usual. And we have another comment from Susan. She's also going to share families are being told that it might be safer for the more complex kids not to return to school at first. And that's also interesting because I know in some places they've actually started by bringing children at least who need special education services. Of course, that's not limited to children who have medical complexity, but I'm sure there's a lot of balancing of those needs as well. And never mind the stress that it puts on caregivers, which will continue to be an important conversation. So with that, Jonathan, do you have anything else you want to add?
Not at this time. Let me take myself. Not at this time, other than to reiterate where I started earlier, with a thank you to all of our presenters. First off, really appreciate the insight. Marilyn, Dr. Perrine, thank you so much. Dr. Warren, for your consistent, the Bureau and for the CDC's consistent participation in this call. And then again, thank you all for your time and all the work you're doing with your constituents in your states and territories. As Amy mentioned, June 25th is our next time to meet. Please be on the lookout for invitations from information from us around next steps around the telehealth COVID opportunity that AMCHP is leading. We are, I mentioned this briefly, but the first pass, first part of that project is an environmental scan, and we won't be able to sit with everyone, but we are going to select a number of folks that may be representative of the states and territories to sit down with and have an interview with, while we're also pulling in resources from other data sets from partners. So please be on the lookout for information around that in the very near future. But thank you again for all you're doing, all your sacrificing, and for your leadership, and looking forward to seeing you on June 25th. Thank you all, and thank you, Amy and Jess. Have a great day.